We're going to go ahead and start this morning's panel, our roundtable. And the title of the roundtable is We Have the Data, Now What? Using Data and Statistics to Drive Policy Change. We'll do some brief introductions. One housekeeping matter is that we will have a little time for audience questions, but if you have their note cards over there to the left, they'll be passed around. If you have a question, fill out the note card and give it to staff, and they will give us the note cards toward the end. So, my name is Charnel Herring. I serve as the Majority Leader in the House of Delegates here in Virginia, and with me is...
And I'm Delegate Shelley Simons. I'm the Chair of the K-12 Education Committee.
And then with us, we do have legislators, participants as well.
Hi, I'm Delegate Carrie Coyner. I represent the 75th House District in Virginia, Chesterfield County, City of Hopewell, and Prince George County.
And I'm Delegate Juwan Ward. I represent the 87th House District, which is the City of Hampton and Virginia.
And I'm Delegate Roja A. Henson Jr., representing Prince William County and Fairfax County.
Thank you all. And with our distinguished panelists, we'll start to my left. If you could introduce yourself.
Hi, Shana Purcell, Director for the Virginia Neonatal Perinatal Collaborative.
Hi, I'm Dr. Tashima Lambert-Giles. I'm an OBGYN at VCU Health, and I serve as our DEI lead in our department.
Hello, I'm Dr. Rochelle Davidson Monday, and I am in the Department of Global and Community Health in the College of Public Health at George Mason University.
Hello, I'm Dr. Yvonne Commodore Mensah. I'm an associate professor at Johns Hopkins Schools of Nursing and Public Health. I'm a nurse and cardiovascular disease epidemiologist and health equity researcher. Thank you.
I'm Juanita O'Brien, State Representative from the Ohio House of Representatives.
Good morning. I'm State Representative Felicia Robinson from the Florida House, representing District 104, which is South Florida.
Good morning. I'm State Senator Tamika Isaac Devine from the state of South Carolina. I represent District 19, which is the Midlands area, Columbia, the capital.
Good morning, everyone. I'm Representative Diamond Staten Williams from North Carolina. I represent District 73, which is a suburb of Charlotte, North Carolina, and I'm also a nurse by training.
Good morning, everyone. I'm Delegate Jennifer White Holland. I have the pleasure of representing the 10th Legislative District in Maryland and Baltimore County. Thank you.
Good morning. I'm Dr. Leah Alexander. I'm the Chair of Public Health at Meharry Medical College.
Good morning. My name is Stacy Brayboy. I'm the Senior Vice President for Public Policy and Government Affairs at March of Dimes.
Good morning. My name is David Vamonde. I'm the Vice President for Data and Analytics at the Virginia Hospital and Healthcare Association.
Hey, thank you all so much, and thank you for being here. I'm going to turn it over to Delegate Simons.
Thanks, everyone. Our first question, we really want to hear from our legislators, and everyone else, of course, can chime in. But over 30 states in the U.S. have established maternal health task forces or similar initiatives aimed at addressing maternal health disparities and improving outcomes. In your opinion, what has worked in your state and what has not? And how can data collection on Black maternal health be improved to inform better health policies? And we want this to be free-flowing, but I do have the representatives here. Representative Robinson or Representative Brent, do you all want to chime in?
Person hold.
Oh, yeah, it's a white mic button on your panel. We'll turn on the mic.
Okay. Different state, different rules. Thank you.
I know. And just another housekeeping rule, when you're done speaking, if you could turn the mic off, because we're limited to only a certain number of mics being on. Thank you.
Okay, I appreciate that. Juanita Brandt from the Ohio House of Representatives. One thing that we realize that particularly when it comes to data, the data dictates where the money needs to go. Because when we have to do things, it has to be right size. We cannot do a
creamy peanut butter approach where everybody gets a little taste of it, because the difference that we're trying to make has to be very intentional with that. So when people say they don't want to collect data, you're basically saying you don't want to know where we actually need to be putting our money, our resources, the policy that needs to be right-sized. So that's been what we've tried to do, particularly in Ohio, is try to do that. We're still fighting for data, but that's a whole systemic issue that people don't want to realize where the numbers really are. But that's the biggest thing of how we've been able to allocate our money.
Okay, so I'm State Representative Felicia Robinson from Florida, and I'll break it down. Strategies for improving the data collection, I'll start there. I think first we need to really standardize, make a standardization for the data collection, developing standard protocols across the health institutions to ensure consistent data is very important. Then we have to look at the use of desegregated data, ensuring that the data is desegregated by race, ethnicity, and income levels. Collaboration with community-based organizations, incorporation of social determinants of health, and the integration of patient feedback. Those would be the things that I think that we really need to do to improve our data. When we look at Florida, things that we have done, we've created the task force. We have a task force that's the Florida Prenatal Quality Collaborative, which is hosted in the University of South Florida, which has made some strides in improving maternal and infant health outcomes. So we're happy about that. We also have the Maternal Mortality Review Committee, which it investigates maternal deaths to understand underlying causes and disparities. We've also increased the focus on Medicaid expansion, where we've expanded the access to postpartum Medicaid from 60 days to 12 months. So those are some things that we've done. Where I think we still need some work in Florida is, although they have these task force, it's inconsistent reporting and the data sharing. We struggle with fragmented data collection systems, and that's why I said that we need to have something that's standardized. We know that we need to have the community engagement, but there is still a lack there. There's insufficient focus on implicit bias training. While Florida has taken some steps in the right direction, we still haven't quite gotten it right yet. And so what I would say is, by improving coordination among healthcare providers and expanding community-based approaches and address the implicit bias in healthcare data collection and policy development in our maternal health, would definitely enhance and bring everything together. So Florida has gotten a start, but we're still deep in the work.
What about hearing from Maryland? Could Delegate Holland tell us a little bit about what you all have achieved with regards to data?
Yes, well, thank you, and again, appreciate the opportunity to share. So in Maryland, we are glad that we have a Maryland Healthcare Commission, and this is the entity that's responsible for collecting hospital data. They are essentially the data hub, and then there are several, as we've heard from others, various task forces. There are work groups. There are technical advisory groups. The one thing that I have observed is that there are silos within silos, and I think that this also presents a challenge when it comes to our data collection efforts, but we're glad that we have an entity that collects a lot of this quantitative data. One of the things that I was very pleased to champion this last legislative session earlier this year was the Maryland Maternal Health Act. And when we talk about data, it's about making sure that it's more tangible, it's more accessible for all of us to access. While I appreciate the various entities and spaces that are responsible for data collection, it is oftentimes very difficult for people like us to go in and actually find what we're looking for. And it has a tendency to be very quantitatively focused. It does not incorporate the nuances and the texture with qualitative data, and ensuring that we are capturing what does respectful care look like, and ensuring that the care that we know that birthing people need and deserve is being captured beyond a scale of 1 to 10. And so through the Maryland Maternal Health Act, it incorporated a report card to be developed by the Maryland Healthcare Commission, making it more tangible and accessible for people across the state to access and get a sense of the birthing outcomes of birthing hospitals that are disaggregated by age, by race, and location, getting a sense of what is the rate of cesarean sections and vaginal birth deliveries, and making sure that we are even incorporating qualitative data and validated instruments. And so it's my hope that through that mechanism, and just the other day this week, they hosted a call with community members and community providers to share feedback about what this report card will look like. And so, as it's been shared before, we have to do a better job in connecting the dots between our state agencies and community-based providers. But there again is an opportunity for us to lead with this report card as an opportunity for us to better collect data and to provide it in a way that is more understood and can be used as a tool. So that is one thing that we're doing in our state, and also working across the board to de-silo these silos that we're in.
Mm-hmm. Thank you. What about some of our other legislators from North Carolina, South Carolina, Texas? Do you all have any experience you want to share on what you've done to, have better data, but also maybe have better public-facing data that community members can easily access?
Yep. They said hold it, and I didn't. So one of the things that we've done, especially in North Carolina for our senators and our House of Representatives, is to really work collaboratively together and looking at different bills that we can put together. So one of the first things that we tried to do is do a Senate bill to aim at implicit bias training. We know that getting that training up front with medical providers and nurses such as myself, getting them through that training and having the funding for that training is going to help improve the access to care that we often see is lacking for our patients, especially in rural communities and within our urban communities as well. In addition to that, we've just implemented, hopefully we'll do this every year. We'll see who our governor is in a couple of weeks. But the awareness of Black maternal health. So every April, we have Black Awareness Week in North Carolina, but that initiative is a social media type of thing. So, but in addition to it being social media and education, we need to make sure that we're partnering with our partner organizations to make sure that individuals in the community better understand their issues, especially when it comes to March of Dimes, especially when it comes to lupus care. One of my patients that I first took care of when becoming a nurse, 18-year-old mom, first-time mom, took care of her for an entire year, and she passed away before she turned 19. So understanding what different disease processes are impacting us in the Black community, especially when it comes to maternal health and the aftercare that needs to happen for us, is important, especially for our providers, because they absolutely don't understand that correlation, and we need them to do a better job of making sure they are on the right side as opposed to doing things retroactively.
Thank you.
So I'll just add, I'm in neighboring state of South Carolina. South Carolina actually ranks the 8th highest in the nation for maternal mortality. And so we've got a lot of issues. I will say that in the last few years, we did establish the Maternal Morbidity and Mortality Review Committee. And so that's really the first area where we've been able to collect data. And then that data has been transmitted to the legislature as far as funding, as has been said before, but just really awareness. And what I found, and this is my first year in the legislature, I found that my colleagues, the awareness was the biggest thing among even legislators. People who are there to set policy don't even recognize some of the issues. Mm-hmm. South Carolina, out of our 46 counties, 14 of our counties do not have OBGYNs. Wow. And so access to health care, prenatal care is critical. So I am happy to say that this legislative session, we actually did fund a mobile maternity unit that will start, is being purchased and developed now. So we'll be going into some of those rural counties to be able to provide health care. We've also started talking about increasing access to midwifery and doulas, because we understand that if you have counties where there's not even a hospital, and we have counties that don't even have hospitals, that those outcomes for women who are experiencing issues will be huge. The other thing that our review committee did point out in 2020, and that's the data that we're working on right now, more than 36% of the pregnancy-related deaths in South Carolina were credited to discrimination. So now, because that data and that number, they can't ignore that. And so when you talk about implicit bias training, cultural competency training among not just our doctors, but our other healthcare professionals is critical. I lost a child. It was stillborn. My child was stillborn, and the time that I went in, right before my child did not have a heartbeat, I did not see a doctor. I only saw the nurse practitioner. And so having doctors trained is one thing, but if the first line that people see are the nurses and the nurse practitioners, others, they have to have that training as well. And so that's important for us. And then the last thing I will say is when going to the data, out of that 2020 report, 94.4% of the deaths in 2020 were deemed to be preventable. 94%. And so, again, having the data is critical when we're bringing awareness. And then once we have awareness among our legislators, we're hoping that that will translate to real dollars and real solutions in our counties.
Thank you so much. What about some of our health experts who are on the panel? Does anybody want to weigh in on, what data sets do you think are the most important in Virginia, and how can we use that data to influence policy?
I would like to add to the conversation, but I'm from Tennessee.
Go ahead.
So we do have those review committees. So we have Maternal Mortality Review Committee, Fetal and Infant Mortality Review Committee, and we have the Perinatal Quality Collaborative. And I know that we have a powerful state legislator that is working very hard, London Lamar, to have more diversity, right, on those groups, so you can hear from people who are affected. And the only other thing I want to add is just to remind us that these are oftentimes stories and data resulting from trauma, and we talk about the numbers, but the numbers are really people. And so we have to sort of honor that and understand that and make space for that.
Yeah, go ahead.
I do agree with Delegate Howland when we talk about the data that we are collecting. When we label hospitals as a birth and hospital, what does that mean? Sure, that they might have lower C-section rates, but that experience that patients might be having is something different. So the qualitative data, I agree, is really important. But I also want us to recognize that there's somebody else on the other side of that as well. We heard a lot of people this morning talk about how important it was to have providers that listened to them, that have providers that they felt comfortable with, to have providers that saw them as people. And I don't think that we're doing anything about looking at the data of those providers and what's happening to the providers that make them lose their idealistic views from the time they went into medical school to the time that they're actually now providing care as one-on-one. Because there's something that's lost there, and we lose our humanism in the structure and the rigor of academic training and physician training, but we're not doing any studies to collect data on how we can actually improve that side of things so that they stay human and they can continue to be humans to patients.
Totally agree. Go right ahead.
Okay, I just wanted to follow up on Delegate Holland's comment about nuance and how we need to rethink how we collect data. The U.S. is changing, and the way we collect data on Black populations should also evolve to reflect the growing diversity of the Black population in the U.S. We know that immigration is a social determinant of health. We have more Black people now in the U.S. who are not born here, who are Jamaican American, Nigerian American, Haitian American, you name it. And so what happens when we aggregate all of their data? We lose these nuances in terms of differences in social determinants of health. In our work, using national data, we've been able to demonstrate that compared to US-born people, foreign-born people have more of these adverse social determinants of health: access to health care, health insurance, education, income. Just last weekend, I was in DC. We're doing a community screening and among women of reproductive age, and a Black woman was walking by, and I started to talk to her. She said no English. She was born in Ethiopia and speaks Amharic, right? And so when we think about Black people, the faces of Black people in the US, that's changing. Their culture, their language. So as we collect data, let's reflect the diversity of the larger Black population in the US as well.
Thank you so much for saying that. So I just wanted to piggyback off to what Dr. Tashima said around providers. So we started a study last year with, in Fairfax, Virginia, with providers, specifically Black providers, maternal health, and a lot of them talked about the training that they would receive around cultural competency, and that it would end within 6 weeks. There would be no follow-up. There would be no sort of like, well, what happens next? And they would speak about their colleagues who are non-Black, who did not have necessarily the connection or interest to go deeper with the training. When we tried to interview other providers who are not Black, they would not join our study. Right, and so there's questions around, well, what happens next after the training has been mandated? What is the accountability? And how are we looking at, like you said, both sides, right? So you have the patient and the provider, but what are providers going through? What are they fearful of? Why are they, maybe don't want to join a study and give insight about what's happening with the training? There's so many other areas of research and data collection that need to happen in order for us to continue to have a comprehensive view of the entire situation. Thank you.
Thank you. Welcome to the legislators who are just joining us. We are diving into data collection on Black maternal health and better ways to inform our health policies. We've got one more. Go right ahead.
Yeah, thank you. David Vamonde with the Hospital Association. So I wanted to kind of go over the data systems that already exist in Virginia. Because Virginia has kind of been a leader in this space. There are 4 really large-scale data systems that are collecting patient data. The patient-level data system, the Emergency Department Care Coordination, which is really ADT feeds, the all-payer claims database, which collects all payer information on the insurance side, and the Unitas e-referral platform. All of these are significant investments that Virginia has made in collecting really good data. And I'm glad to see Maryland here because Maryland is kind of a leader in this space in collecting patient-level data. I heard the word silo mentioned multiple times. So we have millions of patient-level data points in these data sets. Where we really fall short is that these data sets are contained for the business unit in which they collect information in. So in the hospital data system, you'll find hospital data. But that's not the complete picture of the patient. In the payer data set, you'll find all their insurance information. So as we make policy decisions and we really think about these problems, what we've really struggled with is how to establish the legal framework to actually share data between these entities so that we can come up with a complete picture of the patient itself. And what we find is that when we do that, it leads to all kinds of really important insights that we wouldn't have considered otherwise. Just to kind of give you an example of a couple of things that we struggled with. So in Virginia right now, there really is an outpatient data collection. And so what happens in the physician office is never really reported up. That's really important in the context of maternal health because in pre and postnatal care, we really don't have any information in that we can tie back to policy and outcomes. Social determinants of health. So in 2016, these things called Z codes were introduced to the diagnosis tables that physicians and clinicians use. And currently in Virginia, We started with less than 1% of Z codes reported, and after significant efforts in raising awareness of screening at the physician office and the hospital level, our screening is still below 10%. And so with proper screening, you can diagnose things like unemployment as a social determinant of health. That gets tied back to the patient level record. And I think it's really important as we think of these issues, how can we not create new data systems, but actually make the ones that we have better?
Thank you. Leader Herring and I had the pleasure of serving on a maternal health data task force, and one of our conclusions was that we needed to create incentives for consistently and accurately capturing and submitting those Z codes. And we need to move to the next question unless anybody else wanted to weigh in there. All right, let me turn it over to...
Thank you so much. And for the legislators that have just joined us, at the end of the question, when the panelists are finished, you will have an opportunity to ask a quick, brief question, but we got to be mindful of time. And then the members of the audience are writing their questions on cards, and they will be given to us to ask. All right. The next area we're going to talk about is social determinants. So some believe social determinants play a role in the disparities in maternal outcomes for Black women. However, even wealthier Black women face higher risks than their white counterparts. Are there current policies, education, insurance, et cetera, that you feel are contributing to the problem, and are we missing policies or opportunities related to the overall experience of Black women regardless of income or social status? So our health practitioner professionals, if you want to weigh in first, or anyone want to start with the answer to this question. Anybody?
I will say implicit bias absolutely weighs in, especially considering I'm someone that's worked in the healthcare system for 20 years now, started my practice in mother baby, and have seen how people of color are segregated at times in healthcare based on their insurance, put into quadrants of 4 after they've given birth, versus having that private time with your family in a private room. So understanding how our health systems are playing a part in what is currently happening for people in specific places, and if that has not changed within healthcare systems across the board, where we're not paying attention to people's payers as they come into the system, but we're actually paying attention to the patient, is going to be what I feel is going to be the best indicator of how they are going to get the best outcomes for their care. However, I also know that as I have practiced as a nurse and have seen discrepancies in care, people going off of the standards of care that oftentimes are put in place to be the guardrails for care, we have to make sure that we're paying attention and get into the underlying reason of why our providers, nurses, providers as well, are doing things different. What is causing you to do something different? Is it because you didn't like the way that this person spoke to you? Or is it because you're just flippant about what your tasks are? Are you really there to do a good job as a provider, or are you there just for money? What is your passion? If your passion is not to actually care for people, and we need to be upfront with this, especially in education pathways for people. If your passion is not to care for people and you think that it's just to increase your primary wealth, you're in the wrong profession. And we need to say this more often than not to people as they are matriculating through education paths, because what happens is those people become the people that you have to argue with. Those people are the people that are consistently, even internally, where nurses are like, I don't want to work with that person, or provider, I don't want to work with that nurse. So we have to do a better job in the education pathways for providers to say, this is not the right path for you. And that's okay, because you can absolutely do something else. You can work with data. You can work in a different space if healthcare is actually where you want to be, but actually caring for people and your bedside manner is not there. We need you to do something else, because that's where discrepancies occur. That's where bad outcomes occur, when people are not listened to and cared for properly with empathy and compassion.
Thank you. Anyone else like to weigh in?
Yes, Stacy Brayboy with March of Dimes. And so what I want to say is I absolutely agree with the delegate in regards to implicit bias and providing implicit bias training. I also want to just call attention to the fact that there's structural and systemic racism, and it's embedded within the institutions with their policies and their practices, and that has a long time influence on the health care that is provided. So while we're addressing the educational aspect, there are policies and procedures that are in many of these hospitals, not only hospitals, but in the doctor's offices that need to be addressed, because that's where it stems from. I would also kind of add, to tag on to something else that we're talking about a little bit earlier, is just to let you all know that a focus at looking at how we come up with standardized ways of reporting and collecting data and how we address this is how we're able to track what is happening individually and across the country in various states. And so I think in March of Dimes, we're pushing for surveillance in our research, but also looking at the data, not only as it affects the institutional and structural biases that are embedded within the organizations, and how we look at the data for that, but also how we collectively work to educate our providers in that space. And not only the nurses, but the doctors, and even the frontline individuals that you see when you come into the offices and you're raising your concerns.
I'm Leah Alexander from Meharry Medical College. So I want to talk a little bit about implicit and explicit bias. One of the issues I feel like with implicit bias is that we really all have implicit bias, right? Everybody has it. I share a story about my mom. One time we're driving down the street. We're African-American in an African-American neighborhood, and an African-American gentleman is coming towards us, and she hits the lock on her car door, in this older car, so it was very loud. And I caught the eye of the gentleman that was walking toward us, and he really looked at me with disdain, and I asked my mom, why did you do that? And she's like, what did I do, right? So to me, that's, this implicit bias, because it's running in the background, and you don't even really know, what's happening. So everybody has that, and I think sometimes when we try to have these discussions, people get defensive, right? So I work at Meharry, and I often partner with the PWI across town and have been invited to train over there on implicit bias. And at first I was like, man, I don't know if I want to, do this. And I don't want to give people excuses or, show up to try to, whatever the reason why I was invited there. But I started going, and I still go, and I say to those students, you really have to have a safe space so that you can work this out in your head, because it is real, right? And so I may not do this tomorrow, but today I want to create a safe space so you can talk about this, and we can all sort of share how this really exists, right? Explicit bias is another thing, right? But that's the systems and the racism and, how we sort of get caught up in stereotypes and what we think about people and make judgments about that. But I think, especially with medical education, we have to sort of change the narrative and, give people an opportunity to figure out where they are, and then just keep it in the back of your mind. So I'm going into a room, and let me just not deal with this person based off of what the stereotypes say, or even what the patterns are, because medical education is based off of patterns. That's how they are trained. That's how they study. That's how they come up with recommendations. It's based off of patterns, and oftentimes stereotypes muddle that. And so we have to, we train them in one way, but then we have to give them the space to move away from only doing things based off of patterns and to interact with people that they see face to face. So.
May I add?
I strongly believe that most of us did not go into medicine to hurt Black women. And I will hold true to that consistently, despite how unsafe Black women feel in our offices. But when we ask if there's policies and laws and things that are worsening that effect, yes, if I have $400,000 in student loans, I am going to see more patients to make more money to pay off my student loans because I'm considered a high earner, but I'm still living paycheck to paycheck because I don't come from money, because I have to provide for this same family and pay a mortgage worth of student loans in addition to the mortgage of the place that I'm living in. And some of those places do happen to be in very high cost of living places. I was in a National Service Corps and spent years in DC. I left DC because I couldn't afford to pay for DC with a partner that was not a physician, with a plan to have children of my own, and say I can't afford living in this city and get care in this city and then be able to provide care to patients that deserve my care. Because we're not rewarding or incentivizing providers to actually be providers that care for patients. Instead, we're incentivizing seeing as many patients as you possibly can. So there are policies that we can do to change that. We can incentivize different things so that providers can actually get back to what they want to do and to be good providers. When we talk about things like housing instability is huge, and that really affects the care that I'm doing for a patient. If a patient refuses to take insulin for diabetes because they don't have a working refrigerator to put their insulin in, then that dramatically changes her outcome and what I can do in order to treat the medical comorbidities that she's come into pregnancy with. So there are a lot of things on both sides of the lane that really affects the care that we can offer, the care that patients can accept. In my own pregnancy, I refused to do testing each week because having private insurance, I still had to pay $150 each week for testing. That's sure, that's insurance, but are we actually saying that it's still as equitable care if we're not actually saying that maternity care should be something that everyone deserves, regardless of how they look or where they are? So there's a lot of policies that go into how our patients are being treated and how providers react to patients being treated, because they do feel a lot of pressure in order to do the other things that are being called onto them from a health system or from their own personal lives.
Thank you for that. Anyone else?
Yeah, so I just wanted to add, because she brought it up, is there is policies and things that I think we need to look at when it comes to insurance and healthcare access, because there's a lot of gaps there. Despite you might have someone that may be wealthy and have private insurance, but there's gaps in the insurance of what they can provide, and then also restrictions. And so I think that's somewhere that we can actually look at possibly creating policy to improve the healthcare.
And if I may just add one other thing, we talked. I heard through a lot of the comments about the social determinants, the social and structural determinants, right? And one of the things I know that I receive oftentimes are from constituents around my SNAP benefits were cut. I also notice in our capital transportation plan, transportation funding cut. So your state legislatures are now experiencing a lot of funding shortages, which is then resulting in many of our constituents in the communities that we serve seeing and feeling the realities of these particular cuts and the implications of such. And so I think it's really incumbent upon us when we're looking about policies, we think of health in all policies, right? But when it comes to addressing maternal and child health, it's about looking at the larger ecosystem and what are the other areas that we need to examine, whether if it is food, ensuring that we're eradicating food deserts, right? That we're increasing access to healthier food options in communities, that we are not only providing greater connections for providers to connect patients to services in their communities, but really making sure that the community institutions have what that they need to support the patients in their community. And I would also mention that it is now requiring state legislatures to be more creative in how they partner with private entities to really initiate public-private partnerships to ensure that some of these funding concerns can be addressed and that we are innovative in how we explore 1115 Medicaid waivers, how we change change our state plans, because there are creative things in which that we can do that can look at insurance, look at payment models, and look at how we can better support the community where people live in that addresses transportation, housing, food, and the like. Because without those particular things, everything else can't function. So I just wanted to elevate that, because that also is a part of this larger ecosystem when it comes to addressing things even outside of the clinical space.
Anyone else?
Yes, go ahead.
Yes, I just wanted to quickly amplify the point about transportation. As we talk about social determinants of health and individual level social determinants of health, some of the work that we've done in Maryland, we found that 46% of women of reproductive age had challenges with transportation for healthcare visits. Now let's think about Black women in rural America and right here in Virginia, and what it takes to get to your appointment, all the hoops, childcare, and how inconvenient healthcare is, right? There are other countries where you actually stay in the comfort of your home after you have a baby and someone comes to you. And Maryland has home visiting programs as well to acknowledge that transportation is a significant barrier. How do we address that and make care more convenient?
And it's interesting that the good doctor spoke about these different at-risk factors. In Ohio, we've somewhat addressed it, not saying that we got it all together, but we put our money where our mouth is. One, particularly when it comes to housing, putting $8 million towards housing, particularly for pregnant mothers, because that's probably the most vulnerable time that any woman or person could be in when it comes to lifestyle. You might be with a man, not be with a person, be with another person, whoever you're with, and then all of a sudden now you're on bed rest and you need to figure out where you're gonna live. So that's one thing we put in our operating budget. Also to increasing the Medicaid expansion for 300%, which puts us right there at the average income of people within the state of Ohio for eligible pregnant women to be able to experience that. And also just making it a very one-pager, easy form for WIC and for SNAP, because that might be the first time they've ever had to sign up for WIC or for SNAP. And so if the paperwork is done in a much easier fashion, I didn't realize until all of us legislators had to practice filling out the form how much you have to do to fill it out. And so if we want more people to eat good food, we have to make the process a lot easier. So just even when we're determining of how we feel about, our mothers and our babies, we have to really start it within our budget. Our money has to reflect that. And so we have a lot of great groups. I'm gonna just shout them out because they might be listening. Birth Beautiful Communities, Cradle Cincinnati, Roots, as well as there's some other groups too, where in our transportation budget, now they're able to get bus cars for their people that are going back and forth to the doctor or gonna go see their doula. And so that's become part of our transportation budget. So that's essential transportation. And for those areas where the public transit is not available, then we also give them credits to use Uber or Lyft of their choice. So that's how you just kind of make it for those rural areas where you can just say like, hey, we'll just put that as part of the transportation budget because it's taking care of the people. No different than how states have senior transportation. Now you need to start talking about birthing people transportation as a line item within your state budget to talk about transportation.
So I think one thing that from a policy perspective that we're mentioning, and we didn't mention the access to care, we've mentioned it a little bit, but we've now created a policy for expansion, but we don't have providers that are being expanded to be able to take and provide that care to the patients. So the VMPC, I'm the State Perinatal Quality Collaborative Director for Virginia, and we have access to maternal health care in Virginia. And recognizing that I know access to care has been brought up, but that definition varies based on who you're talking to and which report you're looking at. So Virginia, what we chose to do was to actually look at within a 25-mile radius that someone had to drive to deliver. Not only is it transportation, it's childcare, it's gas, it's having the ability to be able to do that But one thing I also want to point out that has been prohibitive in Virginia, when I started this work in 2012, we had 68 birthing facilities. As of today, I have 49 birthing facilities in Virginia, and the number of deliveries have only slightly declined, roughly between 5,000 to 8,000. So that additional burden is now being placed on providers to now provide that same level of care with an increased number, roughly 25% increase in patient load. So just a couple of things that we've noticed. This report will be available on the VMPC website next week.
I wanted to just add to the discussion about transportation. So again, I'm from Tennessee. We are doing research in this space. So, I mean, really the answer is to eliminate, OB-GYN deserts and to make sure that people, have what they need. But in light of those things not happening fast enough, we are looking at technology and, ways in which folks can have access to technology. So, telehealth. COVID showed us that telehealth works, right? And so, there are examples of, pregnant women benefiting from telehealth. But what I know, because we work with underserved populations, is that people don't have everything they need to do telehealth, and it might not even really be acceptable to me. So what we're working on is kind of a flipped thing where we're training people on how to engage with telehealth and increasing their sort of self-efficacy or their confidence in receiving health in this manner and creating opportunities for them to practice a telehealth session. So when this becomes a possibility for you, your mind is sort of ready to engage in care this way. But that doesn't really speak to, having access to internet and, all of those things, or a phone, so all the logistical pieces that would have to come together for that type of care to really work. And we're doing things with technology. So I have a wonderful partner, Imagine Solutions. She's in California, so she's probably not listening, but she's come up with an app that pregnant women could use to monitor some of these things, and then the data, goes directly to the physician. So, but, can physicians bill for this? Is it going to work again? Is it acceptable to underserved populations? So those are some of the things that are happening at Meharry to try to deal with the transportation issue. So.
Thank you. We're going to turn to our legislators. If you have a very brief question. Does anyone have any questions up here on the dais? Yes, Delegate Keys-Gamarra.
Thank you. I really appreciate this discussion. As I listen to all of the folks working in this area, it occurs to me that oftentimes we may have very knowledgeable people in an area, but then you're working with people who perhaps are not recognizing those issues. And I'm wondering, have you come up with ways to improve perhaps someone who is not culturally competent or not understanding their patients as well as they could? And if you have thought about, secondarily, an impact-focused analysis to help bring about such improvement. Thank you.
So this is David Monde again with the Hospital Association. So from a health system perspective, and we mentioned earlier in the panel, culturally competent care and implicit bias training. So one area that I'm surprised hasn't been mentioned yet that is of extreme value in the health system space are community health workers. And so community health workers, if you really think about it, when you go into a physician office, you have a doctor that is going to spend a brief amount of time with you. But a community health worker is a member of your community that is essentially going to have a much larger amount of time to speak with you, get to know you, and how that relates back to social determinants of health information is that if they know that you are, for example, going through unemployment or sexual abuse or any of these social determinants of health, they can code that information into the system if they're affiliated with either a payer or a health system. And so in Virginia, just to kind of give you an example here, There are roughly 20,000 Black mothers delivering babies on a yearly basis, and about 54 to 60% of them per year are covered by Medicaid. So at VHHA, we have been partnering with our DMAS, or Medicaid agency, to get funding for community health workers. And what we find, not only through the very short amount of anecdotal data that we have, but also with empirical studies at a national level, is that patients that engage with a community health worker have better health outcomes empirically. I mean, no matter how you slice the data, even in maternal health or when dealing with chronic conditions, community health workers are a key part of the solution.
Thank you. I'm going to turn it over to Delegate Simons, because I think we have a little time for, I think, maybe one of the questions.
Maybe questions.
Yes, and we apologize.
I think we've had a number of questions about community activities and our community health workers. And one is, what are community activities that you can recommend for advocacy groups to initiate in the community to educate and inform the community around this important issue?
I can chime in. As I mentioned, in South Carolina, we have 14 counties that do not have OBGYNs. And so we are always trying to find ways to be in the community to get people information, even if they don't have access to healthcare providers in their community. And so what I would say is the community organizations, the best ways, we've got to meet people where they are. A lot of folks, until they are needing the service, they're not going to seek it out. But they will be in the communities, of course, working with faith-based organizations at churches, but also community activities. Folks who already have one child, they're going to be at community events with their children. So that means community fairs. We have had some of our community health providers, our parks actually have someone in the parks, and they'll do line dancing classes and stuff for the kids. And then while they're there, they're getting information from these community organizations. So I just think it depends on where your community is and what they're doing, but we've got to meet people where they are and don't wait for people to come seek the information. We have to be out there giving the information. And a lot of times those are in non-traditional opportunities, wherever it is, if it's not parks, if it's not churches. You know, I've been out at poetry slams giving information out, because we have a certain people that they're not going to come to a church or somewhere else, but they're going to go and listen to some good poetry or some live jazz. So those are kind of places I think that we need to make a point of being, and it be more of the norm instead of a one-off.
It's about right sizing. That was the first, I'm sorry. It was really definitely about right sizing of how we message people. So I'll just say in Ohio, through our Department of Health, they put it on the buses, they put it on billboards, and these are public information that goes around year round. Even at our BMVs, they will have us legislators do PSAs that all of us record for this. And so during certain months, you have certain topics. And so when people go get their driver's license in Ohio, you see your legislators on the big screen talking about a particular topic. For this, it could be maternal health, and about making sure you put your baby on his back when they go to sleep, or what needs to happen within our community. And so having that constantly there, you don't have to just do it at certain times. It just needs to be a vital part of how we budget our money as a state for marketing, that we need to make sure we market these topics all the time. So come to Ohio, you can look at all of our buses. It annoys people to always see the babies and the mamas and people breastfeeding, but I think it gets this point across because you don't have to look for it. It's just there, where the people are, the bus stops, the churches, the convenience stores. We make that an investment. So I think we just have to make things as accessible where people are at all the time.
And so I wanted to join in on the conversation and say at March of Dimes, where we do pride ourselves in research, education, and definitely in advocacy, it is definitely about being able to mobilize your advocates. It's one thing to say that you've got a list of advocates, but being able to mobilize them, it is engaging your advocates and asking them to come and share their stories. The most important thing that you can do is let your members of your districts, for those who are elected officials that are here, and those those of us who are in organizations who are leading and leaning into this work, it is about getting your advocates in front of the community to share their stories. Sharing the stories, listening to the impact is how you're able to get more advocates to participate. It is definitely about engaging and meeting the community where the community is. It is also making yourselves available to partner with your local elected official, your congressional leaders, those roundtables that are held in the various communities. It is about showing up. It is about the messaging, looking at what's happening each month as it pertains to the community overall in the maternal and infant health space, talking about it, being able to highlight it. We have a lot of young people that we need to make sure we engage in this process, that this is just not an older person, a middle-aged person, a black or white issue. We need to engage our younger people, and that means that we've got to meet them at our universities. We've got to partner with our universities so that we can talk about how do we get our doctors trained so that we touch on the implicit bias trainings that need to be offered. I heard earlier in one of the other panels and one of the other speakers, it is also how do we encourage more people to go into the field, people who look like us, to go into the field of healthcare or OBGYN, become an OBGYN, become a nurse, become a nurse practitioner. So it is about the messaging. It's about using your advocates to engage them. And more importantly, it is about partnerships and how you spread the word.
Go ahead, and then I'm going to wrap us up.
Okay, sorry. Another important thing is giving the data back in a meaningful, usable way. We all have the data, but when we want our communities to thrive, they have to be able to have the data to apply for the funding so that we can level set. So giving the data back in a meaningful, usable way. The other thing is partnering with communities. Don't just say you're going to partner, but actually partner with them. We have the fortunate with the VMPC to be partnering with a community organization right now on these maternal health hubs, and that is giving back to the community. So we'll end it up.
Thank you.
The only thing I want to add is that we have to behave honorably in the community, and we have to understand that it takes time to build trust, and you can destroy that trust in a minute. And so, like, as a researcher, you know, the reason I love research is because I'm spending time in the community, I'm sowing goodwill in the community, I'm behaving in a way that my community partners know that I can be trusted, and I always try to do what I say I'm gonna do. We have to honor community in that way if we're gonna, you know, develop these sort of transparent partnerships that will really change things.
Well, I want to thank our distinguished panel. Thank you so much. There's a couple of big takeaways I just got to mention. I mean, those who are affected and impacted have to be at the table. I heard basically we need to make sure that we're incorporating all needs, including transportation. I heard that several times. And also do something with the data. So just don't let it sit, make it work. Just a couple of announcements. We're going to next go to the Patrick Henry building. If you're not a Virginia State Legislator, please know that it's security, so you need a photo ID to get into the building, and it's just like airport security when you go through that building. And then for all legislators, Virginia or not, if you could meet us, go out the member exit, and there will be a photo for all of the legislators we'll be taking together. Thank you so much.
Thanks, everyone.